otherwise. You got to compartmentalize the pathophys in your head because they're 5 different disorders, or you'll get mixed up.
And these actually were pretty helpful. I was
The pictures? Yeah, good. Good. Well, then, yeah, I'm glad we put those in here. Once you, read, you're going to have the class, all of that sort of thing. It'll help you just look at the pictures. Yeah, I think so. Hi, everybody. Good morning. Good morning. It's 9 o'clock. And what I don't see, which I'm glad that you had made the good judgment, is not to miss that because you have to do a test in the afternoon. If you took 10:40 and 10:30, you learned that.
only have one more.
Yes, that you can't take the morning to study and miss your other class, or vice versa. Like you said, they will both on Tuesday. So
I can choose.
you're both on Wednesday. You don't want to rob Peter to pay Paul. That would not be good use of 2.5 hours. So the signing sheet is in the back. If you don't get it, you can get it after the break. What I just gave you, and I gave them for Mr. Armstrong and Miss Brown's groups also. This was the page that was in the appendix. Even says competency 2, page 107. But it didn't get in because we couldn't get it to turn landscape on the PDF file. So we're giving it to you as a handout. And I think this is really helpful. When we talked last week about spinal cord injury, and I was talking about the 7 cervical vertebrae, the 12 thoracic vertebrae, 5 lumbar, and 5 sacral, I'm kind of a visual learner, so I like to have a picture. And so on the left column of this chart is the picture of the vertebral column. And then it talks about what's innervated by that particular, the nerves coming off the cord at that level. The next column is kind of interesting. It says level of injury. Well, the title of this chart is Muscle Functioning and Patient Outcomes. We're always talking about outcomes, right? By level of spinal cord injury. So when you look at C4 and above, it says loss of all muscle functioning, including muscles of respiration. The injuries are usually fatal because of respiratory failure, right? And usually death. So in a very small number of people, in countries like ours, where we have EMS, or somebody responds to a person like Chris Reeve, who you'll see in the video, and does, artificial ventilation and intubation and all of that, and then he spent the rest of his life on a ventilator, most people don't get that, and most people die, right? Because why? How do they die?
Because they can't breathe. Because
Okay.
the diaphragm and the intercostal.
Because the diaphragm is paralyzed. And why is the diaphragm paralyzed above C4? Because the phrenic nerve is comes off the cord between C3 and C4. So if your injury's above that, you've lost your phrenic nerve, which means you've lost your diaphragm. Okay. And then it says C5, and it talks about loss of intercostal muscle functioning, so they're at risk for what? Pneumonia. And then they've got, the things. You don't have to memorize this. This is just sort of an interesting, obviously the neurologist, the neurosurgeon, and physiatrists, and certified rehab nurses probably know this if they work with this population. But it's a nice visual. Also on the right, where it says outcome, if you look down at the bottom, the very last one there, the level of injury says S2 through S4. So what does that sound like? That sounds like the area where you have the reflex arc for voiding, defecation, erections, etc., right? The cauda equina at the S2 through S4 cord level. Interestingly, don't worry about this. It says S4 is vertebral level L1-2. That's actually where, in the vertebral column, those nerves come off the spinal cord. But we're talking here about the nerves, right? We're talking about cord damage, which is nerve damage. So just think about it more as the level of cord, the cord level. And then the right it says what? It says the center for micturition, fancy word for what? Urination. Is located in the conus medullaris at this cord level. Damage of cord at this level destroys the reflex arc to the bladder and bowel, resulting in flaccidity and complete loss of bladder and bowel control, as well as the loss of ability to have a reflex erection. Remember, all people that are spinal cord injured have a neurogenic bowel, a neurogenic bladder, either upper motor neuron or lower motor neuron. And if the injury is at S2 through S4, that's the lower motor neuron because the reflex is damaged. They also do not have psychogenic erections, right? Not connected to the brain. You know, the dirty pictures aren't going to do it. It has to be a reflexogenic erection, which is from tactile stimulation. If the level of injury is at the S2 through S4 and the reflex is damaged, there will be no reflexogenic bladder emptying, bowel emptying, or erections because the reflex itself is damaged. Okay? So I think this is a helpful little chart. Again, don't spend time memorizing it because that's not what the test will be about. It'll be what's the test is supposed to look at, and you're supposed to think about, the guy knows the NCLEX is all this now. What would the nurse do for this patient? You know, what would be the nursing outcomes you would be trying to achieve? What would be the ways to get there using the nursing process? Okay. So let's look quickly, and I mean just in the next few minutes, at the spinal cord injury case studies that you were asked to look at from last week, and then we'll go into competency 3. On page 27, which is actually with competency 2, is a critical thinking exercise case study. And these are all my patients. This was my primary care patient, Charlie W. Page 27 in the study guide. He was a 23-year-old C5 quadriplegic injured in a motorcycle accident. His girlfriend, who was in nursing school, was with him in the accident but has fully recovered. He's a full-time college student studying art and photography. He is 4 weeks post-injury on a striker frame with Crutchfield tongs and 25 pounds of cervical skeletal traction for reduction stabilization of his C5 fracture. Okay, so at that time they had used these turning beds called striker frames, and he was in tongs, which is the same basic concept as a halo. Cervical skeletal traction, keeping his neck stabilized until there was enough healing that the traction could be taken off. Okay, or the cervical traction. And it's all true story. Number 1, describe the rehab goals for Charlie. What will he be able to do independently? So as a rehab nurse, I was responsible for determining that patient's short and long-term goals and then monitoring achievement towards those goals. The same thing the PTs, the OTs, and everybody else did. So what would be some things he could do independently as a C5 quadriplegic? He can breathe on his own without a ventilator. He's at risk for pneumonia, but he can breathe on his own. Good. Airway breathing. He has a patent airway, and he can breathe. Okay, we're watching his respiratory system, but those would be your top 2 priorities. Because he is still at risk for pneumonia. He still had that weak cough because he didn't have intercostal muscles.
He can turn his head.
He can turn his head. Can he lift up his arms? No. Yes. Yes. I wanted you to look at that dermatome chart. The dermatome chart is, can you feel this? Yes. Can you feel this? No. Can you feel this? Yes. Can you feel this? No. That's, remember I said your arm buds grow out like this? So this is C3, this is C4, this is C5. So Charlie, a C3 quad can turn his head. C4 quad can turn his head and shrug his shoulders. A C5 quad can turn his head, shrug his shoulders, and lift up his arms. Because C5 is where they have biceps innervation. And even a little bit of wrist. So with biceps, he could lift up his arm. So we had these guys that were C5 quads who were almost completely independent with some adaptive devices. Because they did have some use of their arms. A C6 quad can turn his head, shrug his shoulders, lift up his arms, and put his arms back down. Because he had biceps and triceps. C7 quads only really have some paralysis right here, but they can use their wrists. And if they have some use of their arms and their wrists, they can put one of those universal splints on that OT makes, and they can stab a fork or a hairbrush or a toothbrush or whatever, and they can get a lot of ADLs out of that biceps. So the answer is yes, he did have some use of his arms. So
what can't he do? I mean, a C5 what can he not do?
Okay, so what can't he do? Anything below the level of injury. So he couldn't walk, right? So how was he going to get around? with an electric wheelchair, right? Now, if he has some use of his arms, he can use the joystick and do it here. Chris Reeve had to use the sip and puff because he didn't have any use of his arms. But yeah, so what can't he do? Anything below the level of injury is loss of motor and sensory. So he couldn't feel or move. He couldn't turn or reposition independently. That's right. He would have to have a personal care assistant. It is amazing the adaptive devices they can hook up to people that have some use of their arms. To do something like combing hair or eating. He still had to have his food cut up, and he had to have a plate guard so he could stab the fork and eat some. But he could do independent feeding with the adaptive devices. Okay, so we're not going to get into that level of detail because this isn't a spinal cord injury rehab center. But there were a lot of things he could. What else could he do independently? Could he think? Yes. Could he talk?
Yes.
Could he direct his care? Could he ask people for what he wanted and tell them how to do it for him? Yes. So people need to be able to direct their care. He wasn't cognitively impaired in any way. His mother was a nurse, his brother was a doctor, he was very articulate. So he did go back to college. Now, the sad story is that he got a resistant Proteus urinary tract infection with us at the Boston Center, and he did die 2 years later of renal failure and sepsis from a drug-resistant UTI that we just couldn't come up with antibiotics that could treat it anymore. So I told you the end of the story first, but that's okay. So 3 nursing diagnoses for Charlie. So you said potential for ineffective airway clearance, potential for altered breathing pattern because of the shallow breathing and the weak cough, which could affect gas exchange, right? So there are some potential respiratory diagnoses. What else?
Urinary.
Okay, alteration in urinary elimination, right? Related to what kind of neurogenic bladder? What type? The quads had. What type of urinary? It's neurogenic bladder, we know that. So it's not continent. Is it upper motor neuron or lower motor neuron? Right. Is the reflex arc intact? Yes. Is the injury at the level of the reflex arc? Where's the reflex arc? Down here. Where are quadriplegic levels of injury? In the neck. So yeah, he's upper motor neuron. Is he okay, well, so that's good. And then we've got all kinds of other rehab nursing diagnoses, which we talked about in the first competency. Self-care deficit, mobility, bowel elimination. What'd you say? Go ahead. Pain. Potential for pain. Yes, absolutely. Okay, so all of those things. Also, he's 4 weeks post-injury, so don't you think at this point he's pretty upset? Maybe angry? Feeling powerless? 4 weeks, he's had 4 weeks to think about this now. Okay, bowel and bladder training. So we said that he has an upper motor neuron neurogenic bladder. So we're hoping to get reflexogenic or reflexive emptying with a good enough emptying to wear condom drainage to a leg bag or condom drainage to a bed bag. External collection. We have much better condom drainage for these guys than just the little things you see in acute care hospitals that don't fit very well, do they? And then the bowel training would be the bowel program. Having a regular program with the suppository, maybe digital stimulation. Well, that's fallen out of favor again. And having a complete emptying of his bowel in a normal pattern each day or every other day or whatever they choose. Okay? And then number 4. After 3 months in rehab, Charlie has an episode of autonomic dysreflexia. What symptoms does he complain of? What do you assess for? Okay, so what is he going to complain? What is he going to tell you when you walk into the room if he's having this episode?
Sweating above.
Everybody, tell me.
A headache.
Headache? Why?
Because blood pressure is really high.
Because blood pressure is really, really high. Why is his blood pressure really, really high? Right, because he's got some kind of sympathetic stimulation, some kind of noxious trigger, irritating trigger setting off this episode. So because his blood pressure is so high, he's going to have a headache. So what else is he going to have?
Sweating.
Sweating, only above the level of injury, but yes. The body's trying to compensate, so he'll be flushed and vasodilated. Flushing is from vasodilation. Okay. So then what do you assess? You go in and you're going to do your assessment. You can't develop a nursing diagnosis until you do a quick assessment. So what is the quickest focused assessment going to entail?
Bladder.
Okay, now first get vital signs. Want to make diagnosis first.
Blood
So
pressure.
vital signs will show what? How many
Blood
vital
pressure.
signs?
Elevated.
Blood pressure.
Okay, what else? Vital
Increased
signs, okay,
pulse.
pain, maybe, headache, that's pain. What else?
Elevated pulse.
Pulse, what about the pulse?
To
What
be
do you say about
increased. Elevated.
No.
Increased.
Pulse drops, right. The pulse starts out elevated. You read that in the BSS supplement, right? It talks about initially the pulse will go up, but then what happens? The pulse will start to go down. So it's hypertension with bradycardia. Good. And why does the patient start to become bradycardic?
Try to compensate.
Try to compensate. What with the cranial nerves which are functioning? Which cranial nerve slows the pulse rate? The vagus nerve, right? So the vagus nerve tries to compensate, and the pulse goes down. Okay. So you get your data, subjective, objective data, which include your vital signs. You determine he's having autonomic dysreflexia. And then what do you do? Then you have nursing interventions. What's the goal of the nursing interventions? Get the blood pressure to come back down, right? You can't just memorize stuff. It has to all make sense. That's what we're asking you to do with critical thinking. So why do you sit the patient up first? Why in a quad do you want to sit? You want to get an orthostatic hypotensive effect, right? You know that he has weak skeletal muscles, and the patients that are quadriplegic have a high risk for orthostatic hypotension because they don't have the muscles to push the blood back up from their legs, right? So, but this case now you want that because they're having a hypertensive emergency. So you want to sit them up, have the blood pressure come down, and then what's the other main things you'll do? Find the problem. Okay. So what's the three most common causes of the problem?
Bladder.
Bladder,
Tight
right?
clothes.
Bladder is number one, full bladder. If he needs to be catheterized, you could do that, or there's a kink in the tubing. Bowel, right? Check the rectum, or fix it if that's the problem. See, if you find and fix the problem, then the emergency's over, right? And number three would be the skin. But you have to understand why you're checking the bowel, bladder, and skin, or bladder, bowel, and skin, and then what you're looking for, and what you're trying to fix. So if those things don't work, what would be the next step? Now you're also in touch with the physician, especially if you're not on a spinal cord unit where you have all these standing orders and protocols. What do you want to ask the doctor for if you can't fix the problem?
Hypertensive medication.
Medications, antihypertensive medications that are going to work fast. We actually used to use amyl nitrate and break it under their nose. We don't do that anymore. We have nitroglycerin. How does nitroglycerin work? To bring down blood pressure. It's a vasodilator. Good. It's a vasodilator drops the blood pressure. Okay. Or you can use calcium channel blockers like nifedipine, which you can give sublingually. Okay? All right. So that's autonomic dysreflexia. Now let's go ahead and not worry about number 5 here. Let's turn to the back because it comes up again. All right. Page 218. Jeff K. is a 35-year-old C3 quad injured in a diving accident 6 months ago. He is a married school teacher with 2 small children. His 3-year-old daughter was born with spina bifida and is paraplegic. She has myomeningeal. This is true too. He's admitted to your unit from another hospital with 8 decubitus ulcers on bony prominences. 1, 2, 3, 4, 5, 6, 7, 8, right? Well, okay, so he was out in this community hospital in the western part of the state for a while, 6 months. He's been in the ICU, and they've kept him alive, and they're worried about airway, breathing, and circulation. But one of the things that we don't do real well in ICU is nutrition. And so he had lost a lot of weight. You know, he'd had some pneumonia. They'd taken care of a lot of complications. So before you go, oh, that's nursing negligence, yeah, they probably should have done a better job with nutrition and turning, but they kept this guy alive for 6 months. The problem now is we're getting him with 8 decubitus ulcers. So number 2, what are your most important priorities in caring for him?
Pressure bed.
Skin toning.
Okay, so what would you always think of first with a patient like this? What level of injury is he?
Respiratory.
He's C3. Okay, can he breathe on his own? No. Is he on a ventilator? Yes. What's the quickest way somebody in a vent can die? Airway obstruction. What if he gets a mucus plug? So we still have to go there. I wasn't trying to lead you astray. I wanted you to go back to that. He's a high ventilator dependent high quad, so airway. So, the risk for airway obstruction. You have to make sure he has a patent airway. You're suctioning him as necessary. You're preventing ventilator-associated pneumonias, all that kind of stuff. Okay, so still airway and breathing. And you want to maintain, a normotensive, blood pressure, that kind of stuff. Then, of course, it is important that we worry about his alteration of skin integrity. Right. And he was on a Clinitron bed. He had to have flap surgery for one or two of the deeper ones. We were doing dressing changes on his dermal ulcers. And we were concerned about his nutrition. Because you know that if somebody is poorly nourished and they have low blood albumin levels, you can turn them 100 times a day and they're still going to break down. Because it is important to have hydration and nutrition for skin integrity. And then there were all kinds of other psychosocial issues. At least his house was handicapped accessible. Somebody said that to me once, and that's true, because he had a daughter who was in a wheelchair. Lovely couple, lovely wife. He actually did go home. He went back to teaching with an assistant in the classroom. They were both teachers, he and the wife. Okay, we got the skin cleared up. Scott F., page 219. T10 paraplegic injured in a skiing accident. He's an honor student in high school while his parents are dentists. He's 6 weeks post-injury, getting up in a wheelchair for therapy with a Kydex jacket. That's one of those orthotics, fiberglass things that keeps in his case, the thoracic spine stabilized. What do you think Scott will be able to do independently?
He has the use of his upper arms.
He's T10 paraplegic, which is down here. So does he have a high risk for pneumonia? No. Does he have pretty good trunk balance?
Yes.
If he builds up his upper body, what can he do independently?
Feeding.
Everything. But with the possible exception of walking, he can be completely independent in ADLs using a wheelchair, right? They teach him how to use the sideboard to go from the bed to the chair to the car, hand controls for the car. So he actually, pretty much the sky's the limit. Young kid, lots of family resources, intelligent. He's the one that said, I've never had sex before, now I'm never going to be able to. So this is one of those therapeutic communication questions. Remember the PLIS model? It's okay to talk about it, what you really want to know, listen and gather data, give information as appropriate, and then you can refer him to the counselors that work on that. There are special sex counselors for people with disabilities in places like that, where they have a large group of resources. That's why people with spinal cord injury, with new cord injuries, go to a rehab center that does that. Boston, New York, Craig in Denver. I think Ms. Vessel worked at Craig in Denver. National Rehab does it. Kernance does it. But those are special places. Now, you might see these folks later on if they come back to med-surg with some complications. But this is very subspecialized. All right, that's the one where I told you Charlie turned to Scott and said, well, Scott, at least don't worry about your tongue's not paralyzed. And he was 15, and I don't think it made a lot of sense to him. I think he just wanted to know that the girls were going to like him and he was still going to be cute and sexy, which he was. Okay, page 220. Beverly is a 20-year-old T12 complete paraplegic injured in a car accident. She's the one I saw her x-rays, and she actually felt folded back, went out the side window, and her x-ray was like this. I mean, they had to really piece her back together with rods, and that she had a complete cord transection. Okay, she's living with her boyfriend in an apartment, works for the telephone company as a secretary, readmitted for resistant UTI with kidney stones. Some of those UTIs actually are stone formers. What type of neurogenic bladder does she have? How does she manage it? Reflexogenic, which is called upper motor neuron, right? Remember I said with the males they could wear external urinary collection, like a condom drainage condom with a little tube on the end. With women, it's not so simple. With women, they usually have to use Depends, check themselves to see if they're wet. We had one woman who actually had an ileal conduit. She went and had a urinary diversion because it was easier for her to manage her urine in a stoma in a bag. You've done urinary stomas, than to deal with the wet diapers and the skin breakdown. But Bev didn't do that. What type of information would you be sure she has that should be regarding fertility? Is she fertile? Yes, she still ovulates and menstruates. So what kind of birth control would you recommend for her if she's sexually active? Not IUD.
Not IUD.
Condom and
Diaphragm.
diaphragm. Well, they call that barrier contraception. Why not hormones?
It's for
It's for
DDT.
DVT. Okay, good. And the last one's Neil, page 221. Neil C., I don't remember his last name, is a 26-year-old roofer sustained a spinal cord damage at S2 through S3 when he fell off a roof. He's single and lives alone. Number 2, what type of neurogenic bladder does Neil have and how can he manage it? Everybody agree with that? Lower motor neuron, why? Because he's our patient that had the injury at the level of the arc, which most people don't. So the good news is he walked out of the unit. Is he going to be completely independent for ADLs? Sure. Nothing wrong with his arms. He only really had a little bit of foot drop. He really had minimal, loss of mobility and feeling. It was, the down here part. Remember the dermatome chart? So the very bottom is your perineal area. And so that S2 through S4 cord level meant that he wasn't going to have reflexogenic neurogenic bladder. He was going to have a flaccid, lower motor neuron neurogenic bladder. So how did he manage it?
Self-cath.
Self-cath. Could he use his arms? Yes. Could he do it himself? Yes. So he's a patient we said walked out of the unit with a backpack full of catheter kits. And he actually did get, they don't do them as much anymore, but he had one of the newer, nicer at that time, penile implants. So he could pump up the little balloon and get a nice erection. Because he couldn't do that otherwise. He didn't have the reflexogenic erection because the reflex arc was damaged. Okay? So hopefully you've gone through all those and you've come up with the same thing we just talked about. Because it doesn't help to memorize information if you haven't been able to apply it to the case studies. All right. So now we're going to talk about competency 3. And we're going to go on with the concept of neuro. So when we talk about rehabilitation, and you talk about working in a rehab center, I was working in one in San Diego also. We had patients with spinal cord injuries. We had patients with brain injuries. We had patients with strokes. And we had other patients sometimes that had some of these conditions and needed a lot of intensive inpatient rehab. So these are what we call the degenerative neurologic and neuromuscular disorders. The first couple are in the brain, or start in the brain. They affect the whole body. All of these things we talk about in this course affect the whole body. The first one, MS, ALS, Parkinson's, are actually in the central nervous system. The neuromuscular diseases, like myasthenia gravis and Guillain-Barré, or Guillain-Barré if you're French, happen at the level of the neuromuscular junction, where the nerve stimulates the skeletal muscle to contract. Okay, it's not actually starting in the brain. So let's talk briefly about multiple sclerosis. And hopefully you've looked at your stuff in your study guide. I want to point out to you in the appendix, starting on page 222. So let's look at that together. Page 222, 223, 224, 225, 226. All these things that say competency 3 at the top right of the page. These are teaching plans. This is what it's all about, guys. What does the nurse know about the condition so they can teach the patient and the patient's family, or the other unlicensed caregivers? Because remember now, this is a professional program, and you're learning how to be the professional nurse that guides the team, the nursing team, the rehab team, whatever, right? Okay, so we're going to look at these as we go through the slides, because the slides are really just, the knowledge part, pathophys, etc. So multiple sclerosis. Who gets multiple sclerosis? Well, it's an autoimmune connective tissue disease where the body attacks its own myelin sheath, the myelin sheath that protects nerves, right? And it affects nerve conduction. So what age and what gender is higher incidence of getting autoimmune diseases?
Women.
Women?
Between 40 and 60.
Well, yeah, somewhere in the prime of life. You'll see 20 to 40, you'll see 30 to 50. MS is higher incidence in women. I do know men with it, but it's much higher incidence in women. When we talk about autoimmune diseases, what are some other autoimmune diseases we'll study this semester? Go ahead.
Arthritis?
Yes, what kind of arthritis? Rheumatoid arthritis, not osteo. Rheumatoid arthritis, right? You're right. And what's the other? When you surveyed your study guide, what other autoimmune connective tissue diseases in that competency? With rheumatoid arthritis. What about lupus? Isn't that in there? Right. Lupus, systemic lupus erythematosus. You studied inflammatory bowel diseases, Crohn's, ulcerative colitis. So when you think of autoimmune diseases, think of, these aren't connective tissue, these are nervous system, but they're still autoimmune. Think of women, higher incidence in women, and in prime of life, childbearing years, 20s, 30s, 40s. Now, people can live a long time with these conditions, but autoimmune is usually women and usually younger. Parkinson's is not autoimmune. That's more a disease of the elderly, although there are young Parkinsons. Okay, so the pathophys, as I said, is the demyelination of the axons with abnormal nerve conduction. You don't need to know the types of MS. There's like 4 different types. The MS Society says some people have relapsing remitting, which means they can be symptom-free and then the symptoms can return. Some people have progressive, where they get it and it just continues to go downhill. You're not neurologists, so that doesn't matter because the nursing care is going to be pretty much the same. The diagnostic test, when you did your reading in IGGI, the main test now is the MRI, the magnetic resonance imaging. We try not to do the invasive tests if we don't have to. You only want to do the tests that you're going to do something with the information. MRIs can show the demyelinated plaques in the CNS, so it can diagnose and it can follow progression of the disease. You can have computerized tomography, the CT scans. You can do a lumbar puncture. What do they get out when they do a lumbar puncture? What are they looking at? Cerebrospinal fluid, right? So they might find some abnormal immunoglobins in the CSF if they do an LP. But that's invasive, isn't it? And there's something called evoked potentials where they can look at nerve conduction. They can do optic nerve evoked potentials and look at the conduction in the optic nerve, which innervates what? Medical terminology, guys. What's the optic nerve innervate? The eyes. The eyes, good. Because one of the symptoms you know from MS would be the diplopia, right? The double vision and some of the blindness issues. Okay. Some of these are kind of hard to diagnose because there aren't any real elegant tests. There is one for myasthenia gravis, which I'll talk to you about in a minute. Okay, so people with MS can get weakness and paresthesias. What are paresthesias? Numbness and tingling, particularly in the hands and feet, the extremities. Optic neuritis can cause the visual problems, visual field defects, blindness. Cerebellar ataxia. What does your cerebellum control? Balance and coordination. Good. So an ataxic gait would be an abnormal gait, which would put them at risk for falls. Bladder dysfunction. Sometimes they can get problems with neurogenic bladders at some point. I said there's like 5 types, but you're not urologists. So problems with emptying their bladder completely. And then Dr. Charcot, who I'm sure is a French neurologist, identified 3 symptoms, triad means 3, that are associated with MS. One is nystagmus. Now you can have nystagmus with other conditions, even bad migraines. That's it. It's involuntary rhythmic movement of the eyeballs, isn't it? It's involuntary, so it's an irritated brain. Intention tremors. Now tremors are what? Shaking. Okay, so there's 2 types of tremors. In Parkinson's disease, they call them non-intention tremors, which means at rest they're shaking. If they try to make it stop, it can make it stop. But then when they are at rest, they shake. This is the opposite. An intention tremor means at rest they're not shaking. But if they go to pick up something, think of some of you in your first IM injection. Just kidding. I've seen this. Anyway, that's called an intention tremor. So when they're not tremulous or shaking at rest, but when they try to pick something up, for example, they're intentionally doing something, they'll get some shakes, some little bit of shaking. And then scanning speech is an abnormal speech pattern where they're going along and they stop in the middle of the syllable because they're looking for the word. It's just it's a speech pattern deficit. It's organic. It's neurologic, not psychogenic. Okay, so the medications, they don't have cures for chronic illnesses, do they?
No.
Would be nice if there was a magic medication that cured these things, but there's not. So we manage. One of the ways to manage, well, what do we give corticosteroids for? Inflammation. They're powerful anti-inflammatories, right? So one of the things they can give is prednisone, especially if the patient has a lot of itis, itis, like very bad optic neuritis, and they're having visual problems. For the inflammatory complications of these conditions, they can give them corticosteroids. Now, a lot of people don't like to take their corticosteroids for their MS or their lupus or their RA. Because why? Because of the side effects. And what are some of the side effects of corticosteroids? You have to know these in your sleep. Yes, steroid-induced hyperglycemia, right? Their blood sugar can go up. Their blood pressure can go up. Did you say weight gain?
Yes.
Weight gain. That's why people don't like it. They'll get fluid retention, weight gain. They get what they call centripetal fat distribution, where the head the face gets round and the neck gets thick, and they get fat through here. And their arms and legs can get very skinny. They get the little buffalo hump, I said the moon face. But the weight gain, increased appetite, increased blood sugar, increased blood pressure. Long term, they can get osteoporosis, glaucoma and cataracts. I mean, there's a whole list of complications from steroid use. So they can give ACTH, which actually is the adrenocorticotropic hormone, which stimulates steroid release. They can give prednisone, Solumedrol, Solucortef, all of those kinds of things. Dexamethasone, etc. Because it's autoimmune, which means they're hyperimmune, even though their immune system is still not working properly, they can give immune-modifying drugs, these anti-immune drugs, like the drugs we give for organ transplants. They can give drugs to suppress the immune system. They can use Rumitrex, which is methotrexate, an old chemo drug, Cytoxin, some of these other drugs that affect the immune system. Not as much anymore because we now have what we call the ABC drugs. So if you saw that in your competency, the A stands for Avonex, which is interferon beta-1 alpha. B is beta-seron, which is also interferon, beta-1 beta. And Copaxone, the C, is glatiramer acetate, which again is one of those immune drugs, immunotherapy. These drugs are mostly given sub-Q or by infusion. They're very expensive, like a lot of the new drugs. But they are helpful, remember I didn't say cure, in patients who have relapsing remitting MS to try to prevent relapse, to try to keep them in remission. Anybody know the side effects of the interferon type immunotherapy drugs? I mean, you can have a local reaction where you get the injection. But they cause like flu-like symptoms. They're stimulating the immune system, the good part of the immune system. And so they can cause flu-like type symptoms. That's really all we've got right now. There are treatments for symptom management, medications that we give for the symptoms. So the patient has pain, we give analgesics. If the patient has muscle spasticity, we give antispasm medications, like baclofen. They can even give epidural baclofen. The patient has really bad lower extremity spasticity. We give meds for nausea. We give meds to make their bladder empty better. So that's what we call symptomatic management, isn't it? Patient teaching. Look at your teaching plan on page 222. So if you haven't studied this, you want to look at this between now and next Wednesday. The nice thing about these is on the left column it has the teaching principles, and on the right column it has the rationales. So let me point you to page 222 where it goes down to number 9. It says avoid hot baths, overheating, treat fevers immediately, avoid exposure to hot weather and high humidity. Why? Because number 9, heat may precipitate exacerbations or prolong or intensify existing deficits. So if a person with MS gets hot, they can get increase or severity of symptoms. I had a friend who was a race car, well, he was a Navy dentist actually, but he drove race cars on the weekends. And he had to develop himself a cool suit for his race car because he found that by the end of the race, his body temperature had gone up enough that he had numb feet and double vision. He didn't start out with numb feet and double vision, but the heat of the race gave him that. So he made a special cool suit. Unfortunately, now his disease has progressed to the point where he has to stop driving completely because he can't do it safely. But that was a fix for a while. And then tertiary prevention is prevention of what? Complications of the disease. In this case, MS. So you want to prevent injury. Remember we mentioned the ataxic gait, problems with balance. You want to prevent the hazards of immobility, and there's lots of those. The other thing you see is fatigue. Fatigue is number 5 on here. It says number 5 because fatigue is a ubiquitous symptom of MS, meaning common. Teach the patient to limit activities. So with autoimmune diseases, people get a lot of fatigue. It's actually an organic fatigue. It's the buildup of cytokines and other things in the bloodstream. It's not like they didn't get enough sleep. It's just a terrible fatigue. And it feels, autoimmune diseases, lupus, RA, MS, etc., they have a lot of fatigue. So when somebody has a lot of fatigue, don't we teach them to alternate periods of activity with periods of rest? Don't try to do it all at once, and then you ruin yourself for the rest of the day. I learned that when I first got fibromyalgia chronic fatigue syndrome 20 years ago. It's much better now. But they need to manage the fatigue as part of the disease process, right? And then the complications of the medications. We talked about prednisone, which is a corticosteroid, and other drugs they may be getting. So in your Iggy reading, there are charts of medications, okay? So go back over the meds for MS. Okay, let me talk about, and of course, nursing process. So when we're looking at what we do for the patient, we take that information, the pathophys, the signs and symptoms, the diagnosis, the treatment, and then we apply it to what does the nurse do? And what does the nurse teach? And how do you manage these long-term things? People don't really die of MS. What do they die from? The complications of the immobility of the MS. Okay, I'm going to do ALS. I will give you a break in a few minutes. ALS, amyotrophic lateral sclerosis. Not as common. It's not autoimmune. It's actually higher incidence in men in their 50s and 60s. It is a progressive degenerative disease of the motor system. Atrophy of skeletal muscles, atrophy of hands, forearms, legs, and eventually respiratory muscles, and people die of respiratory failure. Sensory and autonomic nervous system is not involved, the mental status is not affected. So that's what Stephen Hawking has lived with for many years, and all he can do now is blink his eyes. He's a famous physicist. If you ever read Tuesdays with Maury, it's a guy going to visit his old professor, I think, who's dying of ALS, amyotrophic lateral sclerosis. It's also called Lou Gehrig's disease. It is terminal over a period of time. There's no known cause, no cure, no specific treatment, no standard pattern of progression, and no method of prevention, because we don't know what causes these diseases. Results in paralysis and death, usually 2 to 5 years. Some people are alive longer from respiratory failure, because it does eventually affect the breathing muscles. So there's no specific test available. They do have elevated creatinine kinase or creatinine phosphokinase, but you see that with other diseases where there's muscle death, like the CK you see for MIs, for myocardial infarction, where there's heart muscle death. This is just a general muscle. Your CPK, your CK can be increased with muscle death, muscle damage. The EMG shows fasciculations and fibrillations of muscles. So fasciculations are what? What are the muscles doing? They're twitching. Fasciculations are twitching. And what's an EMG? What does that stand for? Electromyography, as opposed to electroencephalograms, which we'll do next week with seizure disorders. Electrocardiograms, which is the electrical conduction of the heart. Electromyograms are looking at muscle function. And they'll actually put little needles in. It's not as bad as it used to be. It's kind of, they could set it up now almost like an EKG machine. It's not as painful. So I had one back where they stuck a little needle in and then gave it a shock and then measured how well that shock conducted, that nerve system, that nerve stimulation conducted into a muscle contraction. So electromyograms show fasciculations and fibrillations as the muscles are atrophying. Here's some early symptoms: fatigue, tongue atrophy, good old dysphagia. So if dysphagia is a problem, which it is in this, which is called, we know the definition is difficulty swallowing, then we're concerned about what? Aspiration, airway obstruction. Weakness of hands and arms, fasciculations or twitching of the face, nasal quality of speech, and slurred speech, which is dysarthria, which you're going to hear me doing this semester because I just got Invisalign. This is the latest, greatest kind of braces. But it does affect your speech. I'm slurring. Okay. You may not even notice, but I do. As the disease progresses, muscle weakness and atrophy extend until a flaccid quadriplegia develops with respiratory compromise. There is one drug, which I'm not going to ask you on a test, Rilatech, approved for use with ALS to try to prevent the deterioration as fast. There's symptom management with medications. You need an interdisciplinary healthcare rehab team, which essentially you do for any of these disorders, including now a respiratory therapist. And then as the patient gets to end of life, then you have things like advanced directives, what do people want for end-of-life care, what hospice support can be provided, do they want to have a feeding tube or not, do they want to be on a ventilator or not, and those sorts of things, knowing that if they get on, they won't get off. Okay? That's all I want to say about ALS. Let's do Parkinson's disease, because this is the last of the CNS disorders. Parkinson's is pretty common. If you look at page 223 and 224, so you know of famous people. That's how you can kind of associate this. You know famous people that had MS. Like who? Montel Williams. I'm old. Funicello. Yeah, you have to know. You have to be from this country and know our culture, so I get that. ALS was Lou Gehrig. He was a baseball player. Parkinson's, there's been a lot of people. We had an attorney general. I'm old, Janet. She had Parkinson's. Who has Michael J. Fox? He's one of the faces of Parkinson's. He got it in his 30s. He's had a couple of the surgical procedures, but he's still working with advancing Parkinson's disease. It's the third most common neurodisorder of the elderly. I've also seen second most common. That's not important information. The number one is Alzheimer's disease. But there's about 50,000 new cases each year. So what happens pathophysiologically in Parkinson's? There's a loss of dopamine-producing nerve cells in the midbrain. The midbrain that controls balance and coordination. And there's a neurotransmitter called dopamine that's supposed to be produced and secreted by the midbrain. If it's not, they can develop this movement disorder. Now, there are a lot of different movement disorders, but this is the most common one. So let me say this right now. If you get a question on NCLEX, or you see something, say, in your Kaplan study, and it says, patient has Huntington's chorea, and you think, oh, Mrs. Eng didn't teach us that, I can't answer this question. That doesn't mean you can't answer the question. Because the nursing care plan for a lot of these disorders is pretty similar. You're looking at a lot of the same priority nursing diagnoses. You're looking at a lot of the same nursing interventions with these chronic degenerative conditions and the immobility that's caused, right? Parkinson's you'll probably see. Parkinson's is common. So we're going to talk about Parkinson's as a movement disorder. Understand that there are others. The triad, or the three symptoms associated with Parkinson's, are the non-intention tremors. Remember, we talked about intention tremors. These are non-intention tremors. So when you see somebody at Parkinson's sitting in their chair, what are they doing? Shaking. They're also very rigid. Ever tried to dress somebody with Parkinson's?
Oh, yeah.
They're like the Tin Man, right? Very rigid. And then bradykinesia. Brady means what? Slow. Kinesia is movement. So they move very slowly. They can even have akinesia. Saw a thing about a little special dog this guy had. He'd be walking along. They have a slow, propulsive, forward-leaning gait, because they could fall. And sometimes he would stop. He went from bradykinesia to akinesia. And the dog was trained that when the guy stopped, he was supposed to tap on his foot to stimulate him to start walking again. It's really interesting, a little service dog. So, that's slow movement. Other features, again, that forward-leaning posture, that propulsive, slow gait. They have some problems with movement, some problems with speech. The speech can get very quiet, can get slower. They can have autonomic dysfunction. Autonomic nervous system controls what? You have sympathetic nervous system that can control your blood pressure, heart rate, all of that. And then the psychosocial assessment of someone with a degenerative neurologic disease. Here's some examples of some potential nursing diagnoses. Also look at your teaching plan on page 223.
I have a question.
Yeah.
Someone with Parkinson's and they have the non-intention tremors. What about when they're sleeping? Do they still have them
Yep.
when they're sleeping?
They still shake. One of the reasons they have alteration in nutrition less than body requirements is because the shaking burns up a lot of calories. The other reason would be that they're so slow when they eat. You still want to maintain people's independence as long as possible. You'll set them up. They might need a plate guard or some special adaptive devices, one of those built-up, spoon and fork handles. But they eat slow and they shake. So the shaking is burning calories, and everything is so slow, including eating, that it's hard to get enough calories. But yes, they do. So all of these things, you can tell me like the related tos. Okay. So impaired physical mobility, related to the muscle rigidity and the muscle weakness, right? So they may need a wheelchair, or at least some kind of other adaptive device. The risk for injury, falls, related to, again, same reason, their weakness, their ataxic gait. Self-care deficit, which is what? Eating, drinking, dressing, hygiene, related to the tremors and the weakness. Impaired verbal communication, related to, I said, slowness of speech, decreased speech volume. If you're unable to move your facial muscles, if they have muscle rigidity of the face, number one, they're going to have that kind of flat affect, and number two, it's going to be hard to enunciate. They'll have dysarthria. Ineffective coping, depression, the disability, the disease progression, and constipation is mostly it's a functional constipation. They need to have enough fluid, they need to have enough fiber, they need to have enough movement, getting up and getting around. And also some of the medications can be constipating. So they're also looking at the side effects of the medications. So when we look at this teaching plan, it's actually the front and back, page 223 and 224. These are all related to taking care of a patient with Parkinson's disease. Okay? The treatment for Parkinson's is medical and surgical, but most patients are managed medically by neurologists. And the old standby medication for Parkinson's is Sinemet. Now, I understand that the new NCLEX, thing we always beat you with around here because we're on probation with the state, is that you have to know the generic names of the medications. They are now only doing generic names. So if you're used to saying Lasix and now you have to see furosemide, or you're used to seeing Sinemet and now you have to look for levodopa carbidopa, you've got to learn the generic names. We'll give you both, but they won't. They're only giving you generic names now. And there's a lot of pharmacology on the test now. So Sinemet is levodopa. Levodopa increases the secretion of dopamine. So it's a dopaminergic drug. Remember, that's the neurotransmitter that's decreased in Parkinson's. This is the drug you need to know the side effects of. In Sinemet, there's something called an on-off phenomenon, where they have to keep giving a higher and higher dose of the medication to get a therapeutic effect, and then it can wear off. It can actually stop working. Also, the typical GI side effects, nausea, anorexia, dry mouth. Also, headache and confusion. They can have altered mental status, confusion, insomnia, nightmares, even hallucinations. You'll see that with some of the psych drugs, when you talk about the old antipsychotic drugs, where patients developed a complication called tardive dyskinesia, extrapyramidal side effects. So tardive dyskinesia, or TD, is these involuntary, bizarre movements. So you might want to on YouTube or put in tardive dyskinesia and look at these extrapyramidal effects. They might just be sitting there and all of a sudden their hands fly up in the air, or something like that, or the pill rolling, or the lip smacking. Some of that is related to long-term use of these dopaminergic drugs. And there is something called tardive dyskinesia. Used to see that with Thorazine and some of the old antipsychotics. Bizarre involuntary movements. Patients on Sinemet, which is how we control the symptoms of Parkinson's, is also orthostatic hypotension. So you have to tell people what? Sit up slowly from lying to sitting, sitting to standing where they can. Get orthostatic, drop their blood pressure, and pass out. There are other dopamine-related drugs. These are called dopamine agonists. Now, you know, an agonist works with, or is a positive, so increases the dopamine and increases the benefit of the Sinemet. An antagonist works against. So if it's an agonist, it's going to help dopamine. Parladel, Permax, Mirapex, and Requip. These are some of the newer. They're given with the Sinemet. So when you see these other meds on the chart, mostly they're other classifications of drugs added to the Sinemet to make the Sinemet work better. Or in some cases, they're given with the Sinemet to control the side effects of the Sinemet. So they are controlling tremor, sweating, and tardive dyskinesia. These are old drugs, cogentin, Artane, and Chemidrin, again, that we used to use with psych patients when they got TD. But it controls the side effects of the dopaminergic drug Sinemet. There's another newer category called COMT. These are inhibitors of an enzyme, catechol-O-methyltransferase. If you see ASE on the word, it's an enzyme. These are enzyme inhibitors. Catechol-O-methyltransferase inhibitors. They inhibit the enzyme. They're also added, again, to the Sinemet, used with the Sinemet, to prevent the wearing off phenomenon, so that they don't have to keep giving a higher and higher dose to get the therapeutic benefit. Because what happens with the higher and higher dose? Get more side effects. And then eventually, they might have to put them on what they call a drug holiday, which means to take them off everything, let them clear from their system, which means the symptoms of the disease will be really bad, and then start it again at a lower dose and start building up again. That's what a drug holiday does. It stops the meds, let it clear, and then start it up again. There is a surgery, or types of surgery, called pallidotomies and thalidotomies. They're a type of deep brain stimulation where the neurosurgeon goes in with a heated probe and basically burns out that hyper area, the hyperneuron area of the brain. And it can actually stop the tremors. They haven't found out with long-term studies that it's permanent. Michael J. Fox had one, early in his disease, and he did really well right after that. He really stopped shaking. And then it sort of came back, and he's had another pallidotomy, which again has worked well for a while. It can be very dramatic. For patients who qualify, and I don't know if Medicare or Medicaid would even pay for this, for people who qualify, who come from other countries to these special neurosurgeons, etc., it can be very dramatic. And then we have stuff like fetal tissue and stem cell transplant, which is showing a lot of scientific promise. Okay, so here's the teaching plan and the rationale. So actually, I already brought that to your attention. You're looking at safety. You're looking at medications and med teaching. You're looking at nutrition to prevent or to get good body nutrition and prevent things like constipation. You're looking at swallowing, nausea and vomiting, which can be from the medications, bowel function, risk of constipation, skin breakdown related to the immobility. Okay, that's your teaching plan. So doesn't that look kind of like some of the things you would see with the other neuro disorders? Yes, because a lot of the things are the same. The urinary incontinence, we call it functional incontinence. It's not that they have a neurogenic bladder, but they're just so slow. By the time they get up, get to the bathroom, get their pants down, and sit on the john, they've already peed themselves. So what do? Well, you put Velcro instead of a zipper, because it's easier to open. Velcro is wonderful for people. Or you use a bedside commode or a urinal, especially at night. You have to make sure they're safe getting it off and on the potty chair. But some way to respond to them or help them to do it faster before it's too late. That's what we call functional incontinence. Okay, again, same thing. Anticipate. You got to know what the disorder is, know what to look for. That way you can know what to prevent. You want to be aggressively preventing, but if you have to, you want to aggressively treat any complications, because that's how people really end up in the hospital, isn't it? And there's all kinds of complications people can have with these degenerative neuroconditions. Okay, questions?
So for the meds for Parkinson's,
Cinemed.
so that's the one we need to concentrate on.
Cinemed. Now, you're going to need to know prednisone for this. I'm sure you studied prednisone before, because you studied inflammatory conditions. They use high-dose steroids for asthma. They use it a lot for other, respiratory. For respiratory, it's usually methylprednisolone. It's usually Solu-Medrol. But they can use prednisone, too. We'll talk about Decadron when we talk about the brain tumors, etc. But it's usually a lot, but you got to know steroids. And the side effects are all the same for all the corticosteroids. So think about prednisone for MS. Think about Cinemed for Parkinson's. When we do myasthenia next, after you take your break, because I want you to look at the case studies. We'll do this one and then we'll do the case study. It's Mestinon. It's the anticholinesterase medication. Okay? So let's take a break.
I have a question.
15 minutes, yes?
Patients with Parkinson's disease, is it treatable?
So what did we just talk about? Is it treatable? So what's your definition of treatable? Are you talking about treatable to cure it, or are you talking
Yes.
about treatable to manage the symptoms?
No, I don't mean managing the symptoms.
Well, then you meant to say curable.
Yes, curable. Can the person totally be cured of the
What do you think?
I don't think
No.
so.
The answer is no. Are any of these conditions that we're talking about here curable? No. Can some of them go into remission? Especially the autoimmune ones? Yes. But none of these diseases that we're talking about in 2020 fit the definition of curable. None of them. Spinal cord injury if it's a complete cord transection. Diabetes. I shouldn't say never curable. I mean, there are people, of course, that are in permanent remission from cancer. We call them cured. So, yeah, I mean, there are some people. I don't know of people that just miraculously get better of Parkinson's. It's not considered a curative disease. Is there going to be somebody who's an outlier who's exception? Sure. There's always exceptions. And then with the diseases that have the the remission and relapse pattern, or remissions and exacerbations, as we say, like the autoimmune conditions, they might have a remission. And it may be just related to the course of their disease. Parkinson's is not autoimmune. They mostly just, gradually do progress. Okay? So you have to understand those concepts. That's what we're talking about in 2020, is things that are chronic and manageable. Now, the word treatable could mean treatable, you're treating the symptoms. So treatable is kind of a general term. You're treating them all. You're not expecting a cure. You're expecting to manage the disorder. Okay, break time. How about 15 minutes? 10:20. I want to do the case study for myasthenia gravis. If you look at it ahead, we can start with the case study, which is on page... the teaching plan for myasthenia is on page 226. And then we'll find it. Facial expressions, as they did not seem to reflect his mood. Remember I mentioned about the rigidity and the flat affect. When talking to his customers on the phone, they frequently had to ask him to repeat words. TL went to his physician, who prescribed anti-Parkinsonian medication, such as what? Cinnamon, levodopa, carbidopa. Actually, it's a combo drug. The carbidopa helps to, potentiate the action of the levodopa. Okay, however, now he's having problems with nausea and visual hallucinations at night, and he's still having some difficulty dressing himself. Number one. Okay, so there's 6 questions here. You guys will do number 1. Actually, 1, 2, 3. You guys will do number 2. Okay, because you can turn around, be better. And you guys can turn around with them. Okay. You. Up 1, 2, 3. This way. He's turning. Okay. We might have some overlaps here. Okay, you 4 are going to do number 3. Really number 4. You two are number 5. And you guys are number 6. Okay? So you actually might want to move up now. Because you're kind of hard to work with. Okay, number 6. You're going to have 5 minutes. And then somebody will stand up and give you the answer. 5 minutes. Everybody.
The case study.
And you've got your book. Probably some of you probably didn't bring the book because it's heavy and you're worried about peeps, but it's good if you have the book. It has all the pictures and charts.
Rigidity, the tremors, postural instability, and low movement. Dopamine, which is produced in the pituitary nigra as well as in the adrenal gland, is transmitted to the basal ganglia.
In relation to communication problems,
Well, who's speaking slowly? The family?
No. The patient.
Oh, well, he's already speaking slowly, but okay. You want to be patient.
When they are talking to him, to speak slowly as well.
Okay.
Yeah.
Yeah, and something I'm guilty of doing when somebody's speaking more slowly than me, you can tell I talk fast, is finishing their sentence. Right, I want you to say the rest of the sentence so we can move on. Don't finish the sentence. Give him time, if he's speaking slowly, to finish the sentence. Good, patience. Okay, what else?
We can use the board communication.
Okay,
Yeah.
okay, which is what? It's like an alternative
It's
communication
an
method.
alternative communication method.
Okay.
And recommend to family to read out loud to him, or himself can read out loud so he can
Okay.
hear himself talking.
Okay, okay.
While singing and engage in any type of communication with his family. And inform the family and friends to wait for him to answer the question.
Finish.
Patient and wait for him to answer the question.
Right. Wait for him to finish the sentence. And you also, what I was trying to do is look directly at you instead of looking over here and you're trying to talk and I'm looking over here. Yeah. Look directly, make eye contact, be patient, let them finish. There are also devices that they can put on the phone maybe to make it louder. You know, there are some technologic things that he could do. But mostly it is. I mean, he's still able to speak. It's just going to be lower volume and more slowly. Okay, good.
I also mentioned some
Okay.
medications
Okay.
to take.
Such as?
Oh,
Oh, okay.
but he said he could take some medications, but they would still leave him slightly speech impaired.
Some things that can be beneficial, but not perfect. Okay, okay. And then when you're adding more and more meds, and a lot of these folks are taking like one from column A, which is usually Cinemet, and then maybe they have another one, dopamine agonist, and then maybe they have one of those anticholinergics, and then you're adding a COMT. Now you're talking about perhaps a medication for speech. So you have to be concerned about side effects when you get into some of that heavy-duty polypharmacy like that with a lot. But medication? That's very good. Yeah, I did not know that. Good. Thank you. Number 4. What suggestions would you make to TL and his family about dressing himself? Go ahead. Velcro shoes is a fabulous thing. You know what Velcro is, right? So if the patient has trouble with buttons or snaps,
That would help with the incontinence.
elastic pants, elastic waist, Velcro.
Yeah.
You can put Velcro for a fly. You can put Velcro for a shirt. You can put Velcro for the shoes. What kind of shoes do you want?
Therapy.
Well, good closed toe, rubber sole,
Non-skid.
non-skid. Right, you don't want him in flip-flops, right? Those aren't safe for those of us who try to wear them.
And assistive devices, because they
Okay.
want to put on top, so you
Yeah.
have devices, so you just one pull instead of trying to get it up.
They do, they do. You've seen some of those probably in some of your
We
settings.
also think, yeah,
Yeah,
we also
definitely.
think zippers, because
Okay.
if they can manage to do, they could just pull that also up.
Yeah, yeah, and if they can't do zippers, you could change that to Velcro too, and just go like this. Okay, okay, so there are some things people can use about dressing and grooming and hygiene and all those sorts of ADLs, right? It's more than just the dressing. Good.
I would say like that, most people didn't do the ADL, so when they get them dressed, they weren't combing their hair, it's kind of hard, but I think if you get the big, I call it dog brush. I don't know.
Yeah, well, it's the
You get
big built-up handle.
Yeah, so they can just do like this, because if it's shaky, it still do the function they need for it to do.
Exactly, because they are going to be shaking. Very good. Okay. Number 5. Describe important teaching principles regarding dietary management.
Yes. In this case, actually, we consider two professionals, the dietitian as well as the speech pathologist.
Okay. You want to swallow it out. The dietitian, and what else you going to do?
And then keep the family too. But let's start with the dietitian. The dietitian can order some vitamins, some nutrients to help him, to help the patient. Then the speech pathologist can do a swallowing evaluation and see whether he can swallow well. And then they can put him on like soft diets, on thickener.
Thickener.
Because there's a possibility of aspiration. So they will put him on thickener so he can swallow easily. So that will help him. They also, when you want to feed him, they should sit him upright. You should sit him upright so that way you'll be able to swallow better. And then also the family should try to weigh him on a weekly basis because the 12 months will make him burn more calories.
Right.
So if you don't watch his weight, maybe he will be losing weight.
Right.
So that way.
So a weekly weight is your outcome measure of adequate calorie intake.
Correct.
Good.
Yes, correct, yes.
Good. Okay. Did you want to add anything else to that? That's it? Okay. So we talked about safe swallowing, good, with the dysphagia, and we talked about adding thicket. We talked about, once he knows the swallowing valve, but if there's a little bit of risk of aspiration, he still needs to eat. And so the soft food, the thickened food. So if you thicken things, what do you avoid? What do you teach him to avoid?
Aspiration.
Laying down after eating?
Right, laying down, make sure, and you mentioned that, you have to be upright,
Upright,
sitting up
yes.
good, sitting up well. You avoid thin liquids.
If it's hard for them to chew, you can get a mechanical saw.
Mechanical soft, right? Good,
And
good,
also,
good.
they want him to get like small portions and frequently instead
Okay,
of
frequent
large
small,
portions.
good. Frequent small meals is better. It's better for everybody, but especially when they have this kind of a situation. Okay. All right, good. And number 6, thank you. How would you handle the side effects of the anti-Parkinsonian medications? So I asked you guys to focus on Cinnamon, which is levodopa,
Some of the side effects were orthostatic hypotension.
Okay, tell me what medication we're talking about. Just say it again.
Cinnamon.
Cinnamon. Okay, so we're not talking about all of them here. We're talking about Cinnamon as the sort of gold standard for anti-Parkinsonian pharmacologic treatment. Okay, go ahead.
Yeah, we're talking about some of their major
Side
side
effects.
effects. One of them is the orthostatic hypotension. So you want to teach the patient the gradual position change, or after taking the medication, she gives some time before taking the walk if he has to.
Well, it's not just after taking it, because these are drugs that are given around the clock to maintain a therapeutic blood level. So there really isn't any time he doesn't have it on board. But I see what your point is. Okay, other than orthostatic hypotension, what else?
Dry mouth. The patient suffers from dry mouth, so you want to encourage sip of fluid, maybe water or iced tea. Involuntary movement, you want to encourage exercise as tolerated or range of motion exercise. Or if possible, you can see if you can have physical therapy
Okay,
correction
okay.
bed.
Which patient would you prescribe warm water baths or a hot tub? The Parkinson's patient or the MS patient? The Parkinson's patient. It'd be good for the Parkinson's patient because of the rigidity. Why can't you do it for the MS patient?
They need to avoid
Because it'll make their symptoms worse. So it's contraindicated in MS, and good idea, warm water bath for the rigid Parkinson's patients. Okay, so what else?
Nausea and vomiting. We said the patient could take a med towards the bedtime. I don't know if I have.
Okay.
Or,
You mean antiemetic meds?
yeah.
Perhaps.
And eat a little portion before taking the med, because I guess if the patient feeds heavily, it also encourages nausea and vomiting.
Okay.
And insomnia,
Yeah, that's a big problem, son.
yeah, we said that we could discourage taking long naps during the day,
And trying to sleep at night.
and so they can try to sleep at night, and also have a sleep pattern.
Good.
That
Sleep hygiene, they call it. Good. I try to maintain a regular sleep pattern.
Yeah,
Okay.
and try to know what puts you to sleep.
Okay.
If it's watching TV puts you to sleep, then you go stay on bed while watching TV. So you can
Okay, sounds, makes sense.
And on confusion, we said it's good to always reorient the patient once in a while, especially on the environment and what the patient is doing. Also teach the family members around the patient about what to do and what to expect. That will help the patient.
About the disease and the medications, and now we're talking about the side effects of the medication, which can be problematic. The insomnia, the hallucinations, all that sort of thing. Okay, anybody want to add anything else about side effects? All right, very good. And there's actually something in your teaching plan there about Parkinson's where it's interesting. It says to decrease protein intake with Cinemat because it can affect absorption. It's one of those things on the teaching plan. But don't worry about that, because in general, we want these patients to have, as you said with the diet, we still want them to have a balanced diet. We want them to have fiber. We want them to have fluids. We want them to have, a balanced diet. Okay, there's no special diet for Parkinson's, the healthy diet.
It also said to take this Cinemat on an empty stomach.
Yes, it is better to take the meds on an empty stomach. Now, when we talk about myasthenia gravis, it's not so much about the empty stomach, but we want them to take it half an hour before they eat. That's kind of what you were alluding to. But in myasthenia gravis, we want it half an hour before they eat because it's going to help their muscles to have them swallow safely. And they're going to have the best blood level, which is kind of what you were alluding to, if they take it half an hour before they eat, and then kind of wears off over time. So let's look at myasthenia gravis. Let's look at page 41 in the study guide. K.A. is a 44-year-old homemaker and mother of 2 teenage sons. Okay, so we did this. Let me go through Parkinson's. We talked about the pathophys and the symptoms and some of the nursing management related to the drugs and the communication, etc. All right. Myasthenia gravis. So we know that's an autoimmune neuromuscular disorder where there's autoimmune destruction of the receptors at the myoneural junction. The neurotransmitter at the myoneural junction is called acetylcholine or acetylcholine. So about 100,000 people in the U.S. have myasthenia gravis, or MG. Myasthenia gravis is higher incidence in women, and women at the prime of life, similar to the incidence, the prevalence, not so much the incidence, is much more rare than MS. But related to the autoimmunity, it's higher incidence in younger women. Okay, so the muscles affected don't contract properly, resulting in weakness and fatigue. This is skeletal muscle weakness. The thing about MG, myasthenia gravis, is it tends to start at the top and kind of work down. The autoimmunity, the antigens stimulate antibodies.
It is a
Skeletal muscle weakness, starting from the top down. So it starts with the eyes, they get PTOSIS, ptosis. What's that mean?
Drooping of the
Yep, droopy eyelids or lid lag. And then it goes from the top down and can affect the respiratory system. All right. So about 20% of MG is ocular. These are people who just have ptosis or lid lag, The symptoms come and go, worse when the patient is tired. So they might just have droopy eyelids. That's the skeletal muscles of the eyelids. Some people have mild myasthenia gravis, but it's systemic. It progresses to involvement of the cranial nerves, so it can affect the neck and the face, but it doesn't involve the respiratory system. With autoimmune diseases, remember I say people can have a natural pattern of remissions and exacerbations. So they can get symptoms, a relapse, and then they can get remissions. The moderate myasthenia gravis is more severe. There's difficulty chewing and swallowing. Those mastication muscles and swallowing muscles are skeletal muscles. So now we're thinking dysphagia, aren't we, in aspiration. That's a big problem. Jackie Kennedy's husband, Aristotle Onassis, who was a Greek shipping guy, died of choking, and they found out he had myasthenia gravis. Anybody could die of choking, but people with myasthenia gravis would be at higher risk. And moderate, now it's getting worse, myasthenia, the ADLs are impaired. They could still have some remissions of this autoimmune condition. And then severe, what they call acute fulminating, meaning it's becoming bad quickly. There's a rapid onset of the symptoms, progression to respiratory muscle weakness. Few remissions can be fatal. So up here, what are they talking about? How would somebody die? Not choking, but how would somebody die from myasthenia gravis in a severe form? Respiratory distress, respiratory arrest. Right, respiratory. Good. And they have frequent myasthenic and cholinergic crises. You can go from ocular to facial, masticatory, which is chewing, speech and neck muscles. It affects vision, speech, facial expression, chewing, swallowing, lifting arms and hands. And then it goes down to the respiratory muscles. So they lose their respiratory intercostal muscles. They can become very shallow breathers and trouble with coughing. Can then go down more into the trunk, the leg muscles, etc. Symptoms are worse when fatigued, after exercise, late in the day, when stressed, and during menses for women. A physiologic stress on the body. So the diagnosis is a history and physical. They can do blood work, serum means blood test, for these antibodies. They can do serum protein electrophoresis for the acetylcholine receptor antibodies. That's a fancy test. They can do an EMG, look at muscle contraction. How well is that happening? Electromyography. They can do a CT scan for a thymoma. About 20% of people who have MG, myasthenia gravis, are found to have a benign tumor of the thymus gland. Now, I don't know much about the thymus gland. I'm not sure anybody does. It's here in the chest, and it seems to have something to do with the immune system. So in some people, taking out that thymus gland tumor helps them with remission. It's really a small player in the overall condition. All right. So let's do the study. Let's do the case study now, and then we'll finish the rest of the slides. So you're only going to have a few minutes. All right, K.A. is a 44-year-old homemaker. This is page 41. 44-year-old homemaker of 2 teenage sons. She was diagnosed with myasthenia gravis 2 years ago, which has been controlled with an anticholinesterase medication, pyridostigmine, or Mestinon, brand name, 4 times a day. Over the past month, she has been experimenting with decreasing the dose of her Mestinon because she's felt so good. She was prescribed 60 milligrams of Mestinon 3 times a day before meals, about half an hour before meals, and 1/2 of a long-acting 180 milligram tablet of Mestinon at night. 3 days ago, she began having chills and fever, and her myasthenic symptoms became markedly worse. K.A. is easily fatigued and has been experiencing weakness, bilateral ptosis, mild dysphagia in the late afternoons and evenings. All right, now she's in your unit. Nursing assessment reveals the following data. So you're doing her assessment. You assess that she has severe muscle weakness bilaterally in her arms, hands, and thorax. Her voice is nasal, and she speaks slowly. She is anxious and dyspneic. Breath sounds reveal expiratory rhonchi in the right upper lobe. She has a productive cough. Her complaints of weakness, dysphagia, dysarthria, ptosis, and problems with mobility are more pronounced later in the day. Vital signs are, and you can see those, medical diagnosis at time of hospital admission is pneumonia secondary to myasthenic crisis. Okay. So look at her vital signs. What do you see that's abnormal?
Her temp, her respiration.
She's febrile, 101.4.
Increased breathing.
Oh, respiratory rate
the
is
O2.
28, so she's tachypneic. And what is her O2 sat?
It's
92, which is probably not normal for a 44-year-old woman.
Her BP is high.
Doesn't say she had any other conditions. Her BP is elevated and her pulse is a little high. Nothing terrible. Okay, so you can see where these vital signs are reflective, kind of fit with her diagnosis of pneumonia. All right, so identify and prioritize the nursing diagnoses for KA. We can do that right now, based on this case study.
Sit her up.
Okay, well, first let's do the nursing diagnoses and get our database. And a nursing diagnosis. This is asking for nursing diagnoses in priority order.
Ineffective airway clear.
Is that what you're all going to say?
Because she has pneumonia.
Is that what everybody wants to say first for the top priority? Ineffective airway clearance. Why does she have ineffective airway clearance?
Because she has a
Pneumonia.
Because she has myasthenic crisis, which is making her respiratory muscles weak, which is making it hard for her to breathe deeply and cough, which has led to her admitting diagnosis of pneumonia. CJ's absolutely right. So what's our top 3 priorities when a patient's sick? Airway, breathing, circulation. Okay, so if she has pneumonia because she can't breathe deeply, airway would be our top priority, and that nursing diagnosis is ineffective airway clearance, right? Related to the myasthenic crisis, which has caused the pneumonia. And you have data to support that. What data supports ineffective airway clearance?
her O2 sat, her respiration,
The O2 is down.
her tachypnic.
Okay, no, that's gas exchange. I think it's the expiratory bronchi in the right upper lobe, right? So when you auscultated expiratory bronchi. She also has a productive cough, right? And we know that she has weakness of her muscles. Okay, so airway. Breathing. Now you can say alteration in gas exchange, right? Related to the myasthenic crisis, as evidenced by an O2 sat of 92%. Isn't that gas exchange?
Yes.
Yes. Okay, so we've got airway and breathing. Ineffective airway clearance, alteration in gas exchange.
I have a question.
Yes.
But they're related to, you said, due to
Myasthenic crisis.
No, that's not a medical
Severe symptoms of the disease. Well, it is a medical diagnosis, but we could use it for this case.
Okay.
Yeah, don't
But
worry
normally
about
you're not
that's
supposed to
not
put a medical.
No, I hate that. Hell, it's so hard to say a patient has immobility related to MS without saying they have MS. Anyway, yeah, we won't go into my beliefs about NANDA and all. They're actually, the hospitals don't use it, so they're actually going to go away with it sometime. They're getting ready to shut it down. But anyway, still using it because I think it's helpful. Because nurses do make diagnoses, don't they?
Yeah.
Ineffective airway clearance, altered gas exchange. So those are her top 2 priorities right now. Because if she loses her airway, her breathing, she's going to get intubated, and she could die, right? Okay. So the other there's lots of other diagnoses, but your top 2 are airway and breathing. State the expected outcomes that correlate with these diagnoses. So if she's ineffective airway clearance or potential for airway obstruction, what is your outcome? What would be your expected outcome? Patient will
Breathe no lung. Keep taking that open airway.
okay, which you're going to know because you're going to say patient will have breathing, now she's tachypneic and she has bronchi, right? Patient will have lungs clear to auscultation. Patent airway will be maintained. So she's going to be getting respiratory therapy, isn't she? She's going to have NEBS, she's going to have supplemental O2. So the second one, the breathing, the alteration in gas exchange, because she's breathing shallowly, because she's a myasthenic crisis. So you got to connect these dots. That would be patient will have.
A normal.
What O2 sat with it?
Well, she'll have respiratory rate within normal limits, and what else will be within normal limits?
The O2
The O2 sat, which is a measure of her oxygen, right? above 95, for example. We'll maintain an O2 sat above 95, okay, because she's low. Now, not everybody is low at 92. If somebody has emphysema, that might be their baseline. But in this case, it's low, okay? Okay, so now, why did the physician order the Tensilon to evaluate Ka for a myasthenic crisis? What's a myasthenic crisis?
Myasthenic crisis.
A myasthenic crisis is when the patient is either under-medicated. Now, this lady's under-medicated. Why is she under-medicated?
She's weaning
Because she
herself.
fooled around with her dose. So she felt so good she thought she could cut down her dose. No, 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 no. The reason she felt so good is because she had a therapeutic blood level and it was maintaining her. So when she started fooling around with taking it correctly, she got sick.
Does that mean the body went into withdrawal?
It just meant she wasn't maintaining a therapeutic blood level to manage her symptoms. She dropped, her therapeutic blood level dropped. Same thing if you go your seizure medicines or something where you have to have a therapeutic blood level. Okay, so she's under-medicated. So the symptoms of the disease come screaming back. That's what myasthenic crisis is. These are the symptoms of the disease. Weakness, tachycardia, decreased tidal volume. What's tidal volume?
No.
The volume of air you breathe in an inspiration. How deeply can you breathe? That's tidal volume. Can lead to respiratory distress or collapse or whatever word you want to use. So airway, breathing, circulation. What do we do for myasthenic crisis? Respiratory support, supplemental O2, neb treatments, possibly even intubation and mechanical ventilation if necessary. Increase the myasthenic meds, which in her case means go back on the right ones, the right dose. And treat other conditions, because she could have gotten a pneumonia even if she wasn't taking her meds properly, even if she was taking her meds properly, because she's at risk due to her disease anyway. And anybody can get pneumonia. I can walk down the street and get community-acquired pneumonia. Okay, and then that would make, a pneumonia would also cause the myasthenic disease to get worse. All right, so, what is Tensilon? Tensilon is a test. It's an IV dose of an anticholinesterase medication, in this case edrophonium chloride. They give it IV, it's rapidly acting, and if the patient has myasthenia, they get improvement in 60 seconds. Or if they have a myasthenic crisis and you give it to them, the symptoms will get better, or the symptoms will, the symptoms will improve. So it's rapidly acting and it only lasts about 4 to 5 minutes. So this is a nice test to see if somebody has myasthenia gravis. If they don't have it, it won't help them. If they do have it, they'll get symptom relief in 60 seconds. Tensilon can also be used to differentiate between a myasthenic and cholinergic crisis. Because a myasthenic crisis is under medication, which causes severe disease symptoms. Cholinergic crisis is over medication, which causes the side effects of too much anticholinesterase medication. So if you can't tell which it is, somebody say comes to the ER, they have respiratory distress, they have myasthenia gravis, you can use the Tensilon test to differentiate. So if they have myasthenic crisis and you give them Tensilon, what will happen?
Get better.
They'll get better. If they have a cholinergic crisis and you give them Tensilon, they'll stay the same or even get worse. Right. And the antidote to Tensilon is atropine. So you need to have atropine on hand in case they get worse. And you have to be prepared to intubate and ventilate. So you have to have ventilator support, respiratory therapy on hand.
Atropine is...
Okay, so here's the deal. So here's the I told you what a myasthenic crisis is. You should have all these PowerPoints in front of you. Okay, under medication, which is what we're talking about with Ka. Over medication is a cholinergic crisis. Nausea, vomiting, sweating. What's meiosis? Little pinpoint pupils. Slow pulse or bradycardia. Now, bradycardia is cholinergic crisis. Tachycardia is myasthenic crisis. The lady in the case study had a myasthenic crisis. Her pulse was elevated. Profound weakness, including respiratory muscles. So look at that. Doesn't that happen with both? Right, it does. Because now we've got weakness from too much medication, just like we have weakness from not enough. So the treatment is still airway and breathing, which is respiratory support. And you can give IV atropine as an antidote to those meds, and you can lower the dose of their myasthenia meds for the future. So that's too much or over medication. That's a cholinergic crisis.
The atropine is the antidote for the.
For all of the anticholinesterase medications,
Okay.
which is what Tensilon is. Tensilon just happens to be the rapidly acting, quickly going away one they use for diagnosis and to differentiate myasthenic and cholinergic crisis.
Okay.
The lady in the case study was taking what? What medication was she on? Mestinon, which is pyridostigmine,
Anticholinesterase.
which is an anticholinesterase, right. It helps to increase the circulating acetylcholine at the neuromuscular, or myoneural, same thing, at the neuromuscular junction. Okay, increases acetylcholine to help with the symptom management. Again, not a cure, but people that are taking anticholinesterase medications like pyridostigmine, Mestinon, need to keep well, what do I mean by therapeutic blood level? It means we don't want it to drop below a certain dose or a certain amount in the blood. That's why she takes it 4 times a day with a long-acting one at night. Right? Makes sense? 4 times a day. And when does she take it? 30 minutes before meals. So if you want to correlate that with the teaching plan that's back here, find the one for 226. Okay, 226 is the teaching plan for myasthenia gravis. So for some reason it doesn't have the rationales, but it has the principles. Instruct the patient and family about the following. Number 1, signs and symptoms of myasthenic and cholinergic crisis. Number 3, how to obtain safety equipment. So if somebody goes into respiratory distress, what do they need to have on hand? Suction equipment and a manual ventilator bag. Why do you want the suction equipment? What does that help maintain? Airway. Good. Okay, and then look down on page 226. Look down where it says number 10. Scheduling medication. You all with me? What's it say here?
30 minutes.
To allow 30 minutes before meals. Why? For maximal effect of medication. This is when it's first been absorbed, to assist in chewing and swallowing. It's to have the best possible safe swallowing environment for meals, so they don't aspirate. Okay? And it does talk about soft foods, talks about fatigue, which is alternating activity and rest, etc., etc. So that's the teaching plan for myasthenia. All right, back to KA on page 41. Okay, so number 3, I think we talked about. Why would the physician order Tensilon to evaluate KA for myasthenic crisis? Well, he knows what he sees, he or she, but they don't know whether it's myasthenic or possibly cholinergic. It certainly in this situation looks like myasthenic because she's decreasing her drug dose. Number 4, formulate discharge teaching plan for KA in order to prevent future hospitalizations.
Stick to the prescribed.
Yeah, comply with your medication regimen. Don't fool around with your dose.
And keep respiratory equipment handy.
And know your disease and know your respiratory equipment and know when to call the doctor and know when to come to the hospital. Sure. Here's some other interventions. Mainly it's the medication, like the Mestinon. They can use immunosuppressive drugs because it's autoimmune. They can use corticosteroids if there's inflammatory processes. But that may be, the risk may outweigh the benefits. There's something called plasmapheresis, where they actually take the blood out of the person, pass it through a plasmapheresis machine, clean the autoantibodies out of the plasma, and return it to the patient. Pretty cool. And a thymectomy is what?
Removal of the thymus.
What's ectomy mean? Removal of the thymus gland, if they find a thymoma.
They do a plasmapheresis for something else.
They do plasmapheresis for a couple things.
Do they do that for Guillain-Barré?
Yes,
Okay.
Guillain-Barré. Right, and some other hematologic conditions. All right, so here's the meds. I said they were anticholinesterase. They increase circulating levels of acetylcholine, pyridostigmine, neostigmine. Those are the generic names. The side effects of too much of these medications is what we call cholinergic side effects. So tearing, which is lacrimation, sweating, diaphoresis, bradycardia, bronchoconstriction, and weakness, including respiratory muscles, the intercostals, etc. So if they have too much of the medication, they can get cholinergic crisis. the atropine and darbepoetin. Atropine is the side effect. So if somebody's having these side effects and they're tearing and sweating, what does atropine do?
It increases the, well,
In this case, well, right, but I want more than that. Atropine, what's atropine do? What does it make?
it increases the heart rate.
That's it. It decreases secretions. They use it as a pre-op medication to decrease secretions. If somebody's sweaty and they're tearing, tears coming out of their eyes, you want to dry them up. So atropine would be one of the things the atropine is doing as an antidote. So when you give an antidote, it gets rid of the side effects, right?
Doesn't it also increase the heart rate?
And yeah, it could.
Like
It could.
They give it for ditch.
It could. And isn't bradycardia one of the side effects of too much of this? Yeah, it's part of the cholinergic crisis. So you want to bring the heart rate back up.
Well, no, they give it for ditch toxicity,
They do.
right?
They do. They use it in cardiac for bradycardia.
Yeah.
But bradycardia is part of this situation here, and you want to increase. You want to dry them up and increase their heart rate.
Okay, because our in my last clinicals, we're dealing with that drug, so I was taught it's used for bradycardia.
It can be. Yeah, it's in with the advanced cardiac life support, the ACLS protocols. They do use atropine for bradycardia.
Okay.
They also use it as a pre-op medication to dry up secretions,
Okay.
so they don't choke on them. It's anesthesia. Anesthesiologists like to use that sometimes. Okay, so that's the med. There's the myasthenic crisis. Too much, under-medicated or severe disease symptoms. Cholinergic crisis, too much medication. The problem is both of them can cause respiratory problems. So airway breathing. Monitor the patient's condition. Very, very vigilant respiratory status assessment. Like you said, ABGs, forced ventilation capacity. It's like the pulse. It's like the when you did asthma and you did the peak flow meter and you did pulmonary function tests. That's what that is. How well can they breathe out, breathe out, breathe out, breathe out, breathe out, breathe out? How well are they functioning? Eating and swallowing patterns. Position. Somebody's in respiratory distress. What position are they in? Up. Chest PT, coughing, suctioning, the ambu bag, the suction equipment. Range of motion, activity and rest, patient and family teaching. And then always nursing process. So think nursing process. Got to put it all together. And the last thing is just a little bit on Guillain-Barré or Guillain-Barré. You have a picture there in your study guide for that as well. The competency 3. There's a picture of MS. There's a picture of Parkinson's. Somebody can call out page 45. Okay, there's a lady, page 45. And it says, risk factors, causes problems with, which is signs and symptoms. It does say, if you look at the bottom, begins in lower extremities and ascends bilaterally. So the difference with the weakness, the muscle weakness, is in myasthenia gravis, it's usually top down, which is descending, right? Cephalocaup. In Guillain-Barré or Guillain-Barré, it usually starts in the lower extremities and goes ascending. So it happens really fast. I have a friend whose brother got it. He had weak legs in the morning, and by the afternoon he was on a ventilator because everything happened really fast. Feet were numb, legs got weak, and then it ascended from the bottom up. Ascending is bottom up. Descending is top down. Okay? So all I really want to say about this is that it happens very fast. We don't know why. It's very acute. It's an acute inflammatory process. Causes motor weakness and paralysis. Probably an infective agent like a flu can start it. The immune system destroys myelin. Cranial and motor nerves are affected. Your motor nerves, your skeletal muscles and nerves are very mild. Your skeletal nerves, the nerves that innervate the skeletal muscles, are heavily myelinated. It's the nerves that are myelinated. It's ascending most commonly. Patient can start at the bottom, feet and leg weakness, and become quadriplegic. Decreased or absent deep tendon reflexes, and then as it ascends, they can have compromised respiratory function, loss of bowel and bladder control, and it can go up and cause numbness, tingling, which is paresthesias, pain. It can even affect the cranial nerves. Remember the 12 cranial nerves, so they can have facial droop, dysphagia, diplopia, and speech problems. So if you have respiratory compromise and dysphagia, then we're at risk for airway and breathing and aspiration and or respiratory arrest. They can have autonomic manifestations, labile blood pressure. Labile is the opposite of stable. So if somebody has labile blood pressure, what does that mean to you?
Goes up and down.
It's fluctuating high and low. Labile, up and down. Okay. Cardiac dysrhythmias, problems with the heartbeat itself, and tachycardia. So this happens quickly. Like I said, they can start out with muscle weakness one day or that morning, and by later in the day, they're not breathing well enough. They're in the ER, they're on a ventilator, and they're in the ICU. Airway, breathing, circulation. Diagnosis is pretty difficult. There isn't really much they can do. There's not really definitive early tests. Not like you can with myasthenia. Most important, airway, breathing, pulmonary function. Top priority nursing diagnoses. Tell me again. In this patient who's now going down the tubes because they can't breathe well, and you're going to need to intubate, put them on a ventilator, put them in ICU, is airway and breathing. Ineffective airway clearance related to the muscle weakness of the respiratory muscles and breathing pattern, which can cause problems with gas exchange. Actually, there's three. Ineffective airway clearance, altered breathing pattern, and altered gas exchange. All three of those. So you're really most concerned in the acute phase with their respiratory system. Now, as time goes on, the nice thing about Guillain-Barré, as opposed to the other diseases which tend to be progressive, it happens quickly, but it generally goes away. They generally get better. They may need some rehab. They may need some problems with, walking and that sort of thing. But they generally, they get really bad fast, but then they also get better over a period of time. They may have some long-term disability. Usually it's things like muscle weakness in their legs or something. But in this case, in the acute phase, it's airway management, respiratory function, chest PT, assisted ventilation, which is a ventilator. Sometimes they'll use immunoglobulin therapy, but mostly it's nursing care. So when you think about nursing care, you think about preventing complications of immobility. What level of prevention is that? Tertiary. Measures for pain relief. Assisting with communication. Remember, that's a top priority nursing diagnosis too. Connect with resources if they're going to be going home or if they're going to be going to rehab, get them hooked up with that. Most cases the term is called self-limiting. That's a good thing when you have something that's self-limiting. So is this one curable? Yeah, this one is. It's not anything we do. It's just the pattern of the disease progression. Okay? So here's my very last slide, because you're going to go back, I know, after your PEACE test. And over the next week, you're going to look at your reading and looking at the stuff that we've talked about today, including the case studies and the teaching plans. But as I said, there are nursing diagnoses common to all of these disorders. If it affects airway and breathing, which are those conditions you're most concerned about? Mostly Guillain-Barré, myasthenia, and maybe Parkinson's. Then that becomes an issue. Dysphagia is a big-time priority problem, isn't it? Then you have, the effects of immobility. You have the self-care deficits. You have, the psychosocial issues related to the progressive diseases, the social isolation,
Safety.
that kind of thing. Pardon me?
Safety.
Safety. Absolutely. That's right up there, too. So as soon as you have airway and breathing, the next one is safety, isn't it? Thank you. So we talk about seizure disorders next week. As soon as you have airway and breathing, you're fine. The next one is always safety. Risk for injury. Falls is one kind of injury. There's a whole bunch of types of injury. You can bleed out, whatever. But falls. So all these patients, because of their immobility and their gait problems and all of that, are at risk for falls. So big time fall risks. Once you've got a patent airway, they're breathing okay. If they're not, that's top. If they are, then you definitely have to always be considered with safety. And when we do nursing, we're doing them all at the same time. So, when you're learning something new, it's okay to learn it in outline form. But when you're actually out there doing nursing process, you have to think about all these things pretty much at the same time. But you still have to act in priority order, because you can only do one thing for the patient at a time. So if my patient's having difficulty breathing, I'm attending to that first. I'm sitting the patient up, I'm doing good respiratory assessment, I'm contacting the physician, or I'm calling the rapid response team, etc. Okay, at that point, the other things aren't as top priority. Okay, we got to make sure you're doing that. Okay, questions? That's it. Thank you. Good luck on your piece test.
Thank you. Oh,
Growth and development.
Yeah. We have lab today.
I love her.
Oh, you do.
And a half hour.
LD. Well, no, LD 5 still sees me at 12.
Yep.
LD 1, I'll see you tomorrow.
3.5 hours.
Right. I'll see you at 12 in the lab. In the
Which lab
front.
is it?
It's the first one on the right.
Okay.
No, I'm wrong. It's the second one. It's in the back. They're all in different places. Your guys are in the back. Group tomorrow's in the front. Oh, I thought I had everybody. Thank you. Do I have everybody's dosage test? I do now. Thank you. You really don't want to know what would happen if you did that. We really don't. We've had a lot of people in this program. We are not playing.
I just get nervous. I'm crazy.
Oh yeah. I'm so nervous about this. I'm scared. I don't know why.
Do you have your keys in this room or are you over there?
The next room.
I'm here at 2. What time are we here? 2?
2:30.
2:30.
Is it here or the
Okay,
other class?
12. We have it in this room.
We have it in this room?
We have Pete's in this room.
No, it's in the other room.
It's in 12. Is it? Well, they all look alike.
Well,
I
these
don't
two
know.
do all seem like.
I follow whoever.
I
I
can't
follow
tell you
people
right now,
like
I'm
that.
in 12, 14, or 16.
All right, Jess. Good luck, honey.
This one seems to have a good temperature, so we're staying here.
Diagnostic procedure. I saw that in the blackboard.
Oh, for today? No, it's fine.
Wish you guys good luck.
I don't know. I just.
We're here.
Let's check the schedule. Check the schedule.
Where is the schedule?
The lab schedule.
Where is it? Oh, here. Yeah. Spinal cord injury.
Right, and then this one was like that. They're pretty much the same as the one. It's not more of that, but they'll be